up there. Okay, so if you could just, Cecile, if you could just advance one slide. That's great. So there may be some new folks on the call today. And so you have access to, first of all, good morning. And you have access in the chat to the program. If you haven't had a chance to get it, there's also will be links in there for the speaker bios and action recommendations. And as you'll see on the hub itself, there's a ton of other, not a ton, but selected materials and resources that really apply to some of the conversations we've been having today and yesterday. And so please make sure you go there. I don't have to remind people that the chat is a wonderful place to add commentary. And in fact, we have a whole list of great commentary that we'll be putting up on the hub. And I'm going to share a few of those with you this morning, very insightful conversations. And in the event, unexpected event of having a Zoom problem, of course, just try to dial back in, or if necessary, we'll all have to just try to just dial back in, but I don't expect that to happen. So, so welcome all, second day of the event. Please advance, Cecile. My driver this morning. I want to just start off again this morning, thanking our sponsors for really enabling us to do this work over this past year. It's been a treacherous and challenging environment for all of us, and in particularly in doing this kind of strategic work. The foresight and the interest and trust and faith in these organizations to actually support this work going into this year was both courageous and really quite appreciated. Let me put it that way. So thank you all for that. And you'll notice on the back of the program, when you have it, you'll see all of the participants in the National Action Agenda, which was more than, significantly more than 150 people and organizations. So again, thank you all for committing the amount of time and resources that you have here. I want to just spend a few minutes before we move into our plenary keynote, which I'm really excited about, just to kind of review a couple of things with you and share some fun stuff. So if you'd advance one more slide here. These are just a few of the responses from the chat, and we'll just leave this up for a minute. And then we have one more slide with the same information on it. Just very rich kinds of textured conversation. You can read through those. And I've been impressed and humbled by the honesty and the directness around really beginning to address some of the issues of race equity and health equity in the comments and in the conversations we were having. Some very insightful kinds of ideas. Next slide, please. I think it ranges from everything from silos to equity choices to how do we fund this work, leadership kinds of questions and conversations. So it was really quite a delight to look through that and to see the level of engagement that's happening. I think that actually any of the sessions we've had so far and we'll have today probably represent an opportunity for much deeper conversations. I know that an hour and a half on things is really quite limited in terms of providing voice to folks, but we'll post the comments on the hub, and you can read through those, and we can actually kind of build an agenda from there as well. So advance one more slide, please. I want to just spend a few minutes on some of the work we've been doing over the last, 10, 15 years, in large part to communicate that the work we've done here in the NAA is instructive and includes terrific recommendations. But what's unique and different about what we're doing here is that we actually have an implementation plan, and that there are actually places that want to implement against these ideas as we go forward. And I think that's one of the unique points of difference here, it's not simply a set of recommendations to hand off to somebody else to go do. It is, we're charging ourselves with actually implementing some of those. And that's part of the reason why we spent so much time yesterday, or sometime yesterday, talking about the Integrated Care for Kids site in New Jersey, because that is our first implementation site. And Dr. McCoy is just an amazing, terrific leader in helping us really take a lot of the ideas and fashion them in order to be able to actually implement them on site. So it's not just the recommendations, but it's the action. And what we at Stewards bring to the table is a lot of time and experience and methodologies to actually help implement some of this. So what I wanted to share was some of that work to show the depth of experience and how we come to the table, and a set of tools that are useful. One of the things that I took away from yesterday's conversation historically has been that lack of a common language or common vocabulary. And that I think that to make this interoperability work happen, and I think that we heard this yesterday, was trying to bridge both internally inside organizations and across organizations, really fighting against the whole concept of silos and all of the scaffolding that goes in to really isolate and insulate us from one another. And I think in large part that is because we are all speaking different languages, either from a functional perspective, from a programmatic perspective, whether or not we're making policy or making technology or implementing programs and working with clients, everybody comes to the table with a different language and vocabulary. So I want to share two things with you, which I think have applicability in general to places doing this work, but specifically in terms of New Jersey, what we plan to do there. And so if we go to the next slide, one of the things we've done is we have done a lot of graphic illustration to capture best practices over the years. And what I want to do is this is a 3-minute tape, and hopefully it will work well. And it'll give you a sense of the breadth and the depth of this. It's also something we would have actually put up and had you sort of interact with if, in fact, we were in Palo Alto doing this work. So just to move away from the virtual a little bit to what the possibilities could have been had we actually been together, I want to show you the first iteration of our interoperability mural gallery, which we put up about 2 years ago in San Diego at the San Diego CIE Summit. And so, Cecile, let's see if this works. If it does, it's great. And it's just 3 minutes here. A little louder. Good.
I've never seen anything like this, either for interoperability or for something else. The idea of having these live notes that are built as almost a body of knowledge growing is truly innovative and really pushes it forward.
Often we go to conferences and we hear all these big ideas, but very often they're very abstract. But this gallery is a great example of showing you individual stories of how to make that into concrete details.
It actually tells a story that makes sense. It's just amazing. I've never seen anything like it.
You go to conferences where there's poster sessions but there's other like visual representations of work.
Right.
But these ones are unique. I think the way that they're done kind of draws you in as the viewer.
I am struck by the amount of work that's been done and the historical perspective of the work around public health and systems change and the data and all of it. I think this gallery is powerful in that way. I've never seen anything like it, honestly.
It really helps open your eyes. Being here in this hall with all the visuals of the work that's been done over the last decade plus.
Just walking around each one of these beautiful murals is a snapshot in time of the human experience. Like, where are we with what's working and what's not?
I think it's phenomenal. I didn't realize it was this rich history. I think I'm on a couple of these things. I've taken part in a couple of these things, but I've learned a lot, and it's great, the presentation.
Really exciting for us to be here with all of our murals and all of our examples of work we've been doing for the last 10 years and the journey we've been on to drive interoperability and information sharing. We've designed it so it's portable because we want to be able to take it on the road and share it broadly across the US and for communities who are trying to drive interoperability and information sharing. It's been really exciting over the last couple of days here to actually see people and hear people's experience with the murals. It's incredibly stimulating to folks, and it really conveys the history of the journey we've been on, and a lot of people at this conference have been on, to really drive interoperability and innovation over the last 10 years or so.
Interoperability, I think, is lost on a lot of people. What this gallery does is create a visual representation that makes it digestible, easy to understand, and really hits home just how important it is.
Thank you very much. If we can go back to the slideshow. That's great. Thank you, and thank you for the internet gods for allowing this to work appropriately. So I hope you get a sense of the breadth and the depth of the work that has gone on over the last 10 years plus around interoperability. And the purpose of showing that to you is that there's a history, there's a body of knowledge that has been accumulated within many people on this call and the community that we've been able to assemble over the years. And we don't need to start from scratch. We don't need, every community that does this work does not need to start from scratch, which I think is one of the challenges, is that somebody faces this daunting task of connecting silos and services, and they're faced with just getting to the starting line. And the complexity of trying to do that takes a year or two or more. And that what we're saying is maybe we can expedite that process by bringing together these ideas and thinking. And that really leads to this point of the ITCC curriculum. So over the years, with support from both the Robert Wood Johnson Foundation and the Kresge Foundation, we've started to put together actually a curriculum that talks about how do you do this work? How do you do systems change work? They don't really teach systems change work in health and human services. They teach programmatic kinds of things. And so what we have had the audacity to do is to try to bring together from over the years, concepts, ideas, from both from our work, from work that we've done with Johns Hopkins and Yale and Stanford and other folks in this call. In fact, our speaker, Shmendra, has been a major contributor to our thinking around a lot of these works and these ideas. And so this curriculum is now just going live, and it helps organizations to actually embed the idea of interoperability. What are the core components of those? And in fact, many of the action recommendations you would see in our change drivers, and an approach to how to think about, train, and teach a common language. So whether or not you're from a policy or technology or finance or whatever, you can see the whole client. You can see what your role is and how it plays. And we've created a new word, interoptimability, as though interoperability wasn't complicated enough. But we realized what happens after you actually connect the boxes and wires? What actually happens after you connect the systems? Well, you need people to be able to use that information. You need to be able to interoperate, and you need to be able to optimize. And that really gave birth to this concept of interoperability, which actually came about more than 10 years ago, before the technology and the systems were available to make it happen. And so I want to share that with you. There's URLs, there's connection points. So as we do the work going forward, and as you do the work going forward, I want to let you know that there is a background, there's a basis for actually helping apply and use this work in your own systems. And I think that is something that may be really helpful as we try to accelerate this work going forward. So if you would advance the slide one more. I want to just take a minute to tell you about what the day looks like again. So we're right in the middle now of just a brief opening, and I'm going to introduce Shmendra and Suzanne to talk about interoperability at scale in a moment. After that, we will go back into 3 breakouts again. There's 3 that we have available. One is consent management as a utility. How do you actually do consent management? How can we actually help create an approach and a process that would allow communities to actually tailor and purpose fit a utility for consent management? One of the big issues that came out of the NAA work, and everyone who's trying to do interoperability, is how do you actually do that and not require every system to do it on their own? And that will be a conversation with both some attorneys, some of our federal partners, and folks who are actually doing the work in this area. The second breakout is housing is healthcare. And I mentioned that yesterday for me and for us, a relatively new concept of thinking about the interconnection between those. And we have wonderful presentations both from Arizona, Los Angeles County, providers in Los Angeles and in New York City to really talk about that in terms of a real focus on housing. And as we said, that was one of the 6 areas that came out of the work as well over the last 6 months. And then the third breakout is lessons from abroad. And this is really about focusing on OECD and EU, more broadly in terms of the developing nations, and then also Canada. And so this conversation will be a facilitated discussion with our colleagues from the European Social Network, from Finland, from Dave Ross, who heads a Global Task Force Initiative, and PG Forrest as well from Canadian perspective. We'll finish up with, again, a conversation, a fishbowl conversation around collaboration, which is kind of where we're headed, is how do we sustain and develop this work through a more collaborative effort? And the participants in this include a number of the foundations who've been involved, heard from some of them yesterday. We're really interested in seeing how we can make the whole greater than the sum of the parts. Individually, we can make progress. Together, we can make more progress quicker and farther, I do believe. And so that's the order for the day. And with that, if we can move to the next slide. Right, and so Cecilia, you're gonna stop showing that and Gillian's gonna show her slide. I wanna introduce Shamendra Paul, who I've had the great privilege of knowing for a number of years from our original work at Johns Hopkins when we were holding our symposia there. And I had met him through work we were doing at the Administration for Children and Families around interoperability. And one of my board members who you heard from yesterday in the legal group, Paul Wormley, made a great recommendation, which was that this work is being done elsewhere and we might have some stuff to learn. And so the introduction to Shamendra and the work he was doing at the time in the information sharing environment was eye-opening and brilliant work on how to do interoperability at scale. Following 9/11, all the work that security agencies were tasked to do to improve communication, standards, governance, technology, and a whole host of other things. And we were fortunate enough to be able to broker some conversations between ISC and Homeland Security and HHS. And it really formulated the basis of a relationship that has continued for years now. And so I'm really, really delighted to invite Shamendra to speak to us this morning, along with our partners from Stanford, Suzanne Temeng, who is an assistant faculty director and has been really instrumental and involved in our work over the years with Stanford, looking at really change at scale. And that's one of the things that has been a driving force for us, is how do you do the work? How do you demonstrate the work locally, but then how do you scale it so that it can really affect large scale organizations? And I think today's presentation will ideally open our eyes and share some of the amazing work that's happening at the VA and at Stanford and elsewhere across the country. So with that, I'd like to hand it over to Shamendra and welcome you again for taking time out of your schedule to speak with us here today.
Thank you, Daniel. And I think Gillian's going to bring up my slides. Yep. I'm getting a warning that my internet connection is not stable, so I'm going to turn off my video, and hopefully that's going to help. And then I'll put the video back on when we do the VA next 16. I have to soup the organization with the human capital, with the innovation, especially out in the field. It's been an amazing journey. I come to VA without a strong background in healthcare or benefits administration, but I like to think I'm a quick study, and it's been great to be able to bring experience from other domains of activity, as Daniel highlighted, into VA. I'm also really excited to be able to
got to unmute Shemendra.
For some reason it got muted. Okay, so go to the next slide, please. So at VA, it's all about veterans. I am the Chief Data Officer at VA. My organization is not in the Office of Information and Technology, the CIO shop. That's a little unusual in the federal space, where there's now a large population of CDOs, but they're usually, at least for cabinet agencies like VA, in the Office of Information and Technology, the CIO shop. I'm in the Office of Enterprise Integration, which is sort of like an in-house management consultancy for VA, focused on integrating VA as we serve veterans across the country. I shop the National Center for Statistics, 19.2 million veterans. That's about 1 million more than we'd be able to administrative data. That's through across the federal government. Our veterans are diverse. They use a variety of services. VA is organized around the idea of choice, that veterans choose to use VA. They don't have to. Our veterans skew more rural than the normal than the population in general. We have a lot of minority veterans, and an increasing number of our veterans are women. So at VA, it's about serving veterans. Next slide, please. So, you know, as we've taken this journey, VA has really been focused on data as a strategic asset for some time. I'll give an example here, and I'm going to turn off my video because I'm getting the message about it being unstable. We've been doing data as a strategic asset for some time. A great example is the Million Vet Program, where about 850 enlisted, where we're looking at longitudinal clinical data to create a unique data set that's really going to be driving, and it's currently driving, a lot of very strong innovation around the country. And focused on you know, data as a strategic example. Another example I'll highlight is My Healthy Vet, now with veterans being able to download their health records and access those and share those. Our work with Cerner, implementing Cerner, the National AI Institute, just across the board, we have a strategic asset. But let's be asking, if you go to the next slide, we're asking it, is the status quo good enough? And the answer is no, it's not. There's a series of, you know, and we know that because the Congress is telling us that, our leadership is telling us that, data and analytic leaders across VA is telling us that. The laws here, I want to highlight the Foundations of Evidence-Based Policymaking Act, the Data Act, the Geospatial Data Act. Those are the laws that created the role of the Chief Data Officer, that put in place a lot of mandates for data management, focusing on integrating enterprise data management, data governance, and a variety of other mandates. The Data Act talks about a presumption of openness with data sets and sharing data broadly to spark innovation and things like that. We're also seeing it from our operational leaders across VA, where there's a hunger for authoritative data, integrated data, to support serving veterans and ensuring that we're working towards impact and outcomes. Next slide, please. So, you know, the big idea in our data strategy and our way forward is, you know, calibrating the veteran's journey. Now, VA has been a leader in journey mapping and customer experience. We call it veterans experience. And we use this to help organize ourselves and ensure that we are, you know, working towards constantly improving the experience of veterans, capturing times when we've fallen short in engaging in service recovery. But what we're talking about here is going a step further. So 3 things I'd highlight here. First is the first 40% of a veteran's journey is when they're service members. The veteran's journey actually starts in DoD as the service member's journey. So we work closely with DoD, but having that unified view of that journey of service members and veterans is critical. 2 is you can identify moments that matter across that journey. And it's critical for us to identify the authoritative data requirements at those moments that matter to make sure that the data is managed and standardized and interoperable and used to provide the most effective operational decision-making and delightful customer experiences. Third is longitudinal analysis, right? Making sure that we're thinking about joint analytics between DoD and VA, looking at lifetime outcomes and using that to help drive evidence-based policymaking. So it's a big vision. And bits and pieces of it are in place today, but I think we really want to do more to Cal Veterans Journey and like that. Next slide, please. So where are we headed? We want to strengthen VA as a learning enterprise. We want to help leadership with managed data and a common operating platform around data so that there's federated data management, there's trusted decision support. We're giving operational leaders reliable indicators. We're governing key analytic and operational questions so that we avoid fragmentation and can bridge into more effective knowledge management. We want to ensure interoperability of our data. We want to look at our workforce as an enterprise workforce around data and analytics. We want to do that jointly with DoD, and we want to engage in evidence-based policymaking or strengthen our use of that across the organization. Next slide, please. So on this slide, you see the pillars of our VA data strategy. We are just in the process of issuing it. Exciting under our Data Governance Council, which has a broad and diverse representation across VA. 5 goals: stewardship or data management, analytics, technology, people, and governance. And across the board, we're looking to build capacity and capability as an integrated enterprise. Remember, I told you my office is located in the Office of Enterprise Integration. So key for us is to bridge data stovepipes and to create the data crosscuts across the organization that really allow us to build these capability and capacities across these goals. Across these goals, we have about 22 sub-goals. They're anchored in the data management body of knowledge. We use a maturity model approach to understand where we are, and we'll continue to look at that maturity model to measure progress against implementing this data strategy. Now, the trick is, how do you do it, right? So let's go to the next slide. In my work around interoperability, information sharing, government operations, and transformation, it's been critical to work backwards from mission impact into capacity and capability building. What's on this slide represents 6 initial priority objectives. The list now is 13 to 14. We're considering a 14th one. But these are the first 6 that developed in my onboarding and my travels around VA as I have been building partnerships with operational leaders across the department. So I'm going to talk about each of these in more detail, and I have Dr. Amanda Purnell with me, and Amanda is sort of the prime mover working with our Office of Mental Health and Suicide Prevention on the second from the bottom one here, and I think that's going to bridge into some of the conversation we have later on. So I'm going to go through each of these in detail, so next slide, please. So I mentioned how the veterans journey starts as a service member's journey. We have a joint executive committee between DoD and VA. It's co-chaired by the Deputy Secretary in VA and the Undersecretary for Personnel and Readiness in DoD. I have a tasker with my counterpart in DoD to develop a joint data and analytics strategy. Key to this is that we have several ongoing forums and initiatives across DoD and VA, right? The most well-known one is the Joint Health Record and the work to put in place a single longitudinal health record, but there's a lot of activity. So our goal is to elevate the kind of shared enterprise focus on data analytics across those myriad touch points and shape and guide those through a joint strategy. So that's work that's underway right now, and I can report that we're hosting a summit in late February. And a centerpiece of that summit is going to be looking at opportunities for joint analytics around one transition. The year prior, the year after transition is a critical point for effective policy interventions, evidence-based policy interventions that lead to better lifetime outcomes. And then the second is around mental health and suicide prevention. The DoD has got a very particular interest in traumatic brain injuries, for example, and microconcussions and how they play. And VA, we have a similar interest around mental health and suicide prevention. Here, this is interesting for this community that's highlighted the use of NEAM, the National Information Exchange Model. That model and program office is now hosted in DoD. And one of the things we're looking at is standardization of core service member and separation and veteran information. And that core person information, that's a sweet spot for NEAM. So we're looking at, the potential for NEAM to help us with upstream standardization to the services and the Guard and Reserve, and downstream standardization of the consuming programs of that core information. Next slide, please. So this represents an assessment that I did early on in around electronic health record syndication. Syndication is the return path for data, clinical data from Cerner Millennium back into VA's corporate data warehouse. That return path is important for, because of the need to support legacy analytics that's driven off of data in our corporate data warehouse and enterprise reporting. It's a good entry point. And the key idea out of that assessment was it's complicated enough to do data management with Vista. If we add Cerner and we have to operate both side by side for some transition period, we need to dramatically mature our data management, data governance, the tooling we use to do that, and how we manage end user requirements, the key analytic question idea I talked about earlier. Next slide, please. So I mentioned earlier that my office, we run the National Center for Veterans Analysis and Statistics, and we have a couple of predictive analytic products. One of them is US Vets, which is microdata on 43 million veterans, 19.2 million living veterans. The other is our veteran population projections. So this is a snapshot of that. And I'm dialing into this meeting from the Commonwealth of Virginia. And I just want to highlight on here that Virginia is increasing its population and coming up to the 4th position from the 7th position from 2020 to 2030. So go Virginia. Next slide, please. In addition to championing the workforce and specific examples of analytics and data management, I also have a data analytics mission management role. And the secretary in the fall put out a memo that talked about the strategy and roadmap, and this is an excerpt from that memo. But this kind of hints at how we're trying to integrate the work of the Data Governance Council in VA and the work of organizing investments across VA into budgeting and management and acquisition processes in VA to make sure that we're using all of our tools to help drive greater alignment and interoperability and support the targeted outcomes I described earlier. Next slide, please. We're going to talk more about this, but I'm particularly proud of a summit that we held in the summertime where we brought together about 90 key clinical, operational, innovation leaders from across VA, data leaders, to talk about mental health and suicide prevention, but to engage in second level thinking about where we saw opportunities to advance data policy, remove information sharing barriers, and accelerate analytic tradecraft and collaboration. There was a rich action agenda out of that summit, and that's helping drive the policy agenda for our Data Governance Council. And Amanda Purnell, as I mentioned, is on the the meeting here, and so asked me about this, and I'll ask her to, kind of share her perspective. Next slide, please. So dashboarding and business intelligence is a real killer app for chief data officers, and there's a lot of activity around that theme across the federal space. What you're seeing here is a screenshot of a common operating platform that we've put in place to support our VHA's COVID-19 response. The numbers, the columns represent the different VISNs, the VA integrated service networks, the regional hospital networks that make up the VA system. And there's information about different aspects of, counts for different, the patient life cycle and things like that, COVID-19 patient journey and other aspects. Vaccinations is on here and things like that. And you can drill down on this. This is a live dashboard with, managed and integrated data underneath it. Next slide. So, and again, in addition to that kind of dashboard view, the management view, we also have other views, and one aspect that really has resonated with users of the dashboard is the fact that you can go from the global view and aggregates to drill down to specific facilities, veterans, and the like, because we've been able to effectively manage, integrate, curate data from a variety of different data sources into an operationally useful context. Next slide. So here's a preliminary roadmap, and the specifics are not important. What's interesting is for this group is that we're trying to manage implementation of the strategy, working backwards from mission impact, but across the different initiatives, trying to group like with like under the framework of those goals that I highlighted earlier to drive unity of effort, right, and to break down data stovepipes and to hit head on the cultural and structural impediments to enterprise integration and effectively managing data as a strategic asset. Next slide, please. So happy to take any questions. I think, Suzanne's going to talk a little bit and then we're going to probably have a discussion, but if it's appropriate, I can take some now, but I'd highlight as an information sharing geek, this was a peak moment for me, getting a picture with the Rosetta Stone. The crowd's parted, no federal dollars involved. The wife got the shot. Excited about that and wanted to share that with the group.
Thank you, Shmendra. Let me see, there's been a couple of comments in the chat, but I want to open it up and see if there's any that people want to express. I know, Eric, you were talking a little bit about your experience there, and I think there may be a perception versus reality of services and support from
Yeah, I saw the comment about thank you for choosing VA. I do think there is a narrative around VA. I find the people in VA that I've worked with are immensely talented, and especially when you look out in the field, the connections to the nation's leading research institutions. It's really amazing, the research complex and the operational complex, and the VA culture around service to veterans is really very strong. With the veterans experience work, we're already seeing benchmarks on customer satisfaction that are as good as anything, and in many cases are better than what you find, looking at private sector players. A key part of the strategy here, right, is by taking a data-driven approach, an evidence-based approach, that gives us more data, more evidence to, help evolve the narrative about VA. But I can really reaffirm that, VA is on the move and is taking very seriously these ideas of data-driven transformation and, and the like. There's a question about social determinants of health, but go ahead.
I was just going to say, if I could just add, it's very impressive, Shmendra, what you and the whole team at VA have done. I know there's a lot of messages about challenges at the VA, and I'm not saying that any medical system, especially one at the scale that the VA operates at, doesn't have issues, but it's very impressive to me. The commitment by line physicians, nurses, and staff is overwhelming. And you look at what, where the rubber meets the road and what you've actually done. I have literally gotten sick 3,500 miles away from where I live, walked into an office and they had my complete health record, pharmacy record, everything. I wonder how many people could do that. In addition to that, you look at what you've done in North Chicago by combining the DoD medical facility with the VA to build a comprehensive medical center. A lot of people talk about interoperability, but I am incredibly impressed, and I hope I'm not coming across like the poster boy here, but I am incredibly impressed with what you have actually done. And I will tell you, as somebody who could choose any medical care I want, I'm fortunate that I could afford medical care. I have insurance. I choose the VA because I don't believe I can get better care than the care that I receive right now. So on behalf of a lot of millions of veterans, thank you for what you're doing. And I think you're on the right track. You're continuing to lead the way in terms of pushing interoperability. And that's really what we need.
Yeah, thank you. Thank you for that. And that was great. You said it better than I could. I would highlight that in talking to the transition team, I had an exchange with them, and some of the, one person highlighted, the superpower VA has is the data we have, right? And the key for us to unlocking that superpower is integrating the data, right? Managing it, putting it to use, sharing it around the innovations, around the care model we have, and the leadership that we've provided and could strengthen around American healthcare. So there's a real commitment to innovation, and from the narrow lens, which is maybe pretty broad, but the lens that I have around data as a strategic asset, it's quite exciting, the possibilities and what's already happening, right? The cadre of folks across VA that are committed to this vision, and then the potential for us as we go forward. It's a multi-year journey. It's a daunting, it's a large vision we have, but I think it's there's a lot of support, and we're going to be working it collaboratively. There's some questions in the chat about health equity and social determinants. Those are big for us. I like to joke we were into social determinants before it was cool. We call it the Veterans Benefit Administration. That's a little tongue in cheek, but half of VA is VBA. All the different benefit programs that we realize that we provide. Health equity is a top tier consideration for us. I can tell you, being a part of the COVID response, from day one, we were asking those questions and trying to understand and use data to refine our outreach, to refine policy, to make operational decisions. Health equity is a top tier consideration for us. As I highlighted earlier, about a quarter of our veterans are minority, 20% and growing are women. There's a real focus on making sure that we're reaching out to those individuals, using what we know about them as a population and individuals appropriately and ethically to engage with them and give them meaningful choice. And that's key to our strategy, is accessibility and choice. So,
Shamendra, there's another question coming in. One of the things that I'm always impressed about is the broad view that you bring to data interoperability, and now at the scale of the VA. Are you seeing yet any lessons learned that we can port back over to the HHS? Because it does seem that on a scalability level that we're continuing to start again, over and over again.
So VA is kind of unique. It's such a big agency, but it's somewhat unique in that it's retail, right? I mean, we are 400,000 employees. When you include the health professional trainees, it's 550 plus. But we're retail, right? We serve veterans every day. We serve a known population of veterans over their lifetime. That gives us this focus on enterprise integration and the real desire and hunger to drive on the data management and analytics activities. So that's a little different than, for example, how it was in my previous role, where it was working with state and local public safety, law enforcement, where there was 18,000 agencies and it was distributed and decentralized. I mean, we are pretty distributed and decentralized, but nothing like that, right? But a couple of lessons learned. I think it's always useful to work backwards from the mission, and I think that's a strength of Stewards of Change, right? You guys do the human-centered design, the storyboarding kind of thing, which you were highlighting in your opening remarks, and I think that is a kind of really important idea. Maybe let me ask Amanda, to chime in, given her experiences with the Suicide Prevention Summit and how we've been able to carry that work forward. Amanda, do you want to chime in?
I'll speak very briefly because I very much want to make sure that we get to hear from Dr. Suzanne Tamang. She's fantastic. I really thought it was powerful and impactful during the summit that we engaged first with deep human-centered design interviews, and it's been such a central theme through what I'm hearing, in this event, this virtual event that we're experiencing now, is the importance of understanding the three-dimensional picture and the curiosity and interest of veterans, direct care providers like myself, and people who are working at both the mid-level and senior level leadership and connecting to the mission and in listening and being curious about one another's experience and then using those insights to drive action. So there's a willingness and a curiosity to testing out how might we be transparent about the opportunities for improvement, and then keep ourselves honest about the efforts that we're making and where we're struggling and how we can continue to improve. So I'm really excited about the summit that occurred last summer and the ongoing work and curiosity about ongoing work to continue to improve.
Shamendra, can I ask, have you looked at how or when you will engage across states for your federated record? As I saw in one of your early slides that you show even into retirement and on after discharge. How would you see that engaging across with the state VA offices and for services really for both of you?
Yeah, we expect to be doing a lot of engagement with the state veterans departments, the veteran service organizations, as we further develop our strategy and roadmap. The approach that I've taken, so far is to start inside and, help to organize, fully recognizing that there's already a lot of engagement across VA with state veterans departments and VSOs. Then there's a lot of sharing. I mean, VA is a power user of health information exchanges. So a lot of that work is ongoing, but the starting point on this data work was getting our, internal house in order and building a critical mass of partners where we're driving operational impact to help build the credibility, right, and focus for the, the internal capacity and capability building effort. So I see that as, kind of the work that we have in front of us. And there's some examples, right? Like we have an API that can help folks determine if an individual is a veteran or not. And we expose that API to certain federal partners. There are certain benefits that veterans have from other agencies. And the agencies have to come back and ask questions, is this person a veteran or not? But that same API, which is relatively new, right, would be valuable to state veterans offices to have, that kind of shared information, or that predictive analytic data set I mentioned, US Vets. That would be another one where there would be interest, I think, in collaborating with state veterans offices. So there's some clear opportunities to do that sort of work, but we're not quite there yet. At least I'm not quite there yet. There's others in VA that are doing that work. VA is a big place.
Could I ask a question about whether your office interacts with I think it's called the HUD-VASH program, between Housing and Urban Development, that provides housing vouchers, and the VA supportive housing that then houses homeless vets? I think there's been like 40,000 homeless vets who have been given access to housing over the last decade.
My office doesn't engage with HUD directly. There's folks in VBA and VHA that work with HUD. We are a part of those conversations. And you know, part of what's in my job jar as the chief data officer is to bring a little bit more of an enterprise sensibility to current point-to-point relationships. So that is the kind of thing that we want to be able to, you know, create a little more transparency on. But so VA does that. My office directly doesn't do that work.
Okay.
But HUD has a chief data officer. We have a federal CDO council. We have, you know, there's a push underneath the federal CDOs to, you know, kind of identify opportunities to improve collaboration and coordination, link data sets. So that's in, you know, prospective work, but I'm not there yet, but that is something that occurs. Yeah.
Thank you.
That sounds wonderful. What I'd like to do, Shmender, is ask Suzanne to share some of her work and how it interrelates with the VA, and then reserve a little time for some questions and dialogue as we go forward on that. There you go. Suzanne, you have control.
Great. So I'm based at Stanford, where I work with Center for Population Health Sciences and with the Department of Biomedical Data Science. But I also get to wear a second hat working with mental health operations. And I will be discussing two use cases that both leverage social determinants of health, but also have an eye towards ensuring health equity within the VA and more broadly. And I'll just mention, you know, it's a very unique opportunity. We get to actually apply advanced analytics. Some of these projects are already being implemented, or the next stages that I'm talking about have maybe a 1 to 2 year frontier. So, you know, we talk a lot about using data and models. It really is a wonderful opportunity to do this in the wild. Next slide. So I'm first going to talk about REACH-VET, which is it's a suicide prevention program that's been implemented within the VA since about 2017. And within the veterans population, some research has shown there's up to 20 veterans that die from suicide each day. So this is a very high number, and it's actually greater than the general public. But this is a concern for people in the US more broadly and internationally. Next slide. So the REACH-VET program is designed around suicide prevention coordinators. The data that's actually used for the predictive modeling, it incorporates EMR and other types of VA data from over 140 different facilities. And it really is designed to identify individuals within the VA population that have this statistically elevated risk of suicide, also hospitalizations, and other types of severe adverse events related to mental health. These suicide prevention coordinators essentially use these people with they reach out to the veterans at the elevated risk, either to directly address their needs or to work with their clinicians to do so. Next slide. And these models are mainly built on EMR data now, the traditional type of clinical data, so drugs, diseases, prior comorbidities or existing ones. And what I've been doing with a number of different partners, mainly the Department of Energy, also, you know, through the MVP program, is working with VA data scientists, but also other agency partners to integrate social determinants of health into our REACH-VET models. And we initially focused on detoxification, drug detoxification. That was last year, and we're extending that this year to include 8 others. And what we're focusing on is housing instability, drug detoxification, as I mentioned, justice involved, social connectedness, social relationship status, food insecurity, job instability, access to means, and military sexual trauma. So all of these are clinical concepts that are associated with increased risk that can be used in the models, or it can be used to facilitate clinical decision support in other capacities. And it really does require large data to train these models, to be able to validate them. And although our NLP tools are quite good at more of the traditional drugs and diseases, the social determinants of health are not well developed in terms of these analytic tools. So it really is an innovative area, and also one where I feel some of our products and findings could be useful to health systems outside the VA. Next slide. So this is another one of the models used within mental health operations. It's STORM, and it has a different interface with BHA users. Here it's primarily being used by clinicians, and it's a stratification tool for opioid risk mitigation. And you may have heard, there's a lot more interest in algorithmic bias in predictive models. It really is an important concern. We do want to ensure that these models are fair and equally beneficial to different subgroups of our population. And just to give you an idea of what we mean when we're talking about it with racial and ethnic bias, we want to ensure that these models are going to, one, fairly distribute any sort of resources that are associated with opioid risk among the veterans, and also be able to support the clinicians using these models so they can make the best decisions with the best risk estimates. Next slide. So this just gives you an overview of the actual STORM implementation. Similar to ReachVet, it's not that anyone gets a particular number and they act on that number. Same as ReachVet, and you see this quite clearly here with STORM. It's contextualized with a lot of additional data, one that you may find in a traditional EMR, but also richer types of data. Here, STORM includes both the patient information, risk of suicide, also risk of overdose. These are both estimated with a predictive model. Then you also get to see any clinician using this dashboard, the contributing risk factors that has led to the risk estimate. And then also the risk mitigation strategies. So these can be clinical, they can be psychosocial, and they involve a variety of different strategies. The individuals, anyone reading this dashboard can see what's actually being used with the patient and what they may potentially benefit from. And then also an area for where the care team and follow-up details can be stored. Next slide. And what's really motivating the use of STORM throughout the VA and also with ReachVet, and this is what I love with working with operations partners. They have a direct idea in mind for how it's going to be translated into practice, how it's going to be adopted, what the incentives are. So one thing that's strongly motivating the use of STORM and the continued development is that there are practice guidelines for chronic opioid therapy and substance use disorder. And there are also recommended treatments, but what we do find is that they're not consistently implemented in practice. So this is really a decision support tool that's used within the VA, by hundreds of clinicians each week, and they're actually mandated to use, it need not be STORM, but STORM or some of the other dashboards that are distributed through mental health and suicide prevention office, and they're required to review these before prescribing individuals, new users of opioids. Next slide. And so what we did was I worked with a data science for social good program at Stanford, and also our FDA colleagues at the Office of Minority Health and Health Equity. As I mentioned, STORM is a critical model to the VA. And what we did was over the summer, 2 summers ago, developed different tools, mainly visually driven, and that we could explain to subject matter experts so they could review them, ways to identify algorithmic bias within these tools, and also to look at their potentially decreased efficacy or changes in the level of bias over time. So this shows you calibration, which is actually one of the most, I think, important estimates. And really, calibration is defined by the following property. If you assign somebody a risk of X or a group of X, the actual outcome incidence for that rate should also be X. So if you look at the graph on the left, that diagonal dotted line would show you a perfectly calibrated model. The different colors show you the different subgroups that we have in there of the veterans population, Asians, Black, Native Americans, and white. And if any one line there, each color corresponds with a subgroup. If the line is above that diagonal, it's actually underestimating risk for that subgroup. If it's below, it's overestimating it. And those bars that you see, there's one for each risk decile. So we're mostly concerned with the top 10% often in these models for flagging high-risk patients. So that very last bar is going to be that last decile. And if you take a look at that closer, the width of it's the uncertainty in that estimate. So you see it's much more certain for our white veterans than say our American Indian veterans or even our Asian veterans. But you also see that that model is underestimating risk for Black veterans and some other of our minority veterans groups. And this also shows, we call it in-sample and out-sample validation. So our in-sample was where we're fitting these models to the same year of the data. So essentially using 2016 data to predict 2017 outcomes. But what's often done in practice is you build this model once and then you apply the coefficients or other types of parameters to future data. That's the out-sample. And you could see just by looking at the lines, some of the level of bias changes, but also the uncertainty in the estimates. And unfortunately, where you see the most variation usually is in the smaller subgroups of the population. You know, here you see it more in the American Indians, but also in the Asians. But one nice thing about this is that we do have, more of a whole movement within predictive analytics for building fairer models. So there's certainly some types of solutions that can help to improve these models and potentially reduce some of the bias estimates. Next slide.
Suzanne, can I interject for a quick question here?
Sure.
When I know that bias is a huge topic in the social human services and many other areas in particular, and I'm curious about how that kind of modeling can help either sort of inform decision making around AI in general, or in more general around bias. And are those conversations being had, and is it translatable to being able to use those kind of models to address the issues of bias within more normal general data and analytics and stuff like that, or is that a different area?
Yes, well, I'd say one, it points to the importance of putting context around these models. So if you just produce a number alone, it may be less informative than if you put additional risk factors and other types of context that a clinician or say a suicide prevention coordinator can also use to make a decision. But there are methods, we haven't demonstrated them within these models. It's a conversation with the Office of Health Equity. So we are on STORM version 2 will be coming out soon. So our plan is to apply these to STORM version 2 in conjunction with that office, and really working with subject matter experts there and within mental health operations to identify what they think is most problematic. And although we haven't explored these within the context of STORM, there is research around designing fair algorithms that could potentially address some of these. For example, one may be synthesizing data for essentially, you see some of the biases related to some of the smaller subgroups, and I do think that might be an area where we might be able to synthesize, artificial patients to improve how many data points we have to learn from and potentially reduce some of this bias, which a lot of it is driven by smaller sample sizes. And yes, I just saw the question. Storm version 2 is changing the algorithm, but not substantially. And there are definitely efforts within the VA to take essentially Storm and ReachVet to more of machine learning and deep learning based models. Next slide. Oh, so thank you very much. I think I just went a little too fast. That last slide, I think I skipped on it too soon. Maybe we could just go back one. Yeah, so I just wanted to point out here that some of these underestimates were probably driven by the fact that there were sharp increases in drug poisoning rates around the years that these models were developed, especially among the Black population more generally. So, a lot of these, it really just points to the need for ongoing calibration, developing these, I think, more cognitive diagnostics that are visually driven. I just showed you one before, but we came up with around 5 for working with subject matter experts to really measure and tease out what exactly are these sources of bias, how are they related to subgroups, and of course the population is evolving rapidly, especially in these high priority areas. Next slide. Okay, thank you everyone. Happy to take any questions.
Thank you, Suzanne. So the floor is open for questions for Suzanne or for Shemendra, or in general relative to the work we've been focusing on the last couple of days. So let me just pause for a second. The floor open here. So one of the questions I was going to ask is sort of applicability of the research to practice. I know, David Rekoff spoke yesterday in some about, how do application, how can application really help researchers focus on those questions that are most poignant and pertinent? Clearly, you've talked about both racial bias, and also suicide prevention. What's the interaction, I know, with the medical centers or with populations or with the VA in general around that?
So Daniel, are you asking me or are you asking Suzanne?
Both, actually both of you. Okay. Either one could so jump in there.
Go ahead, Suzanne, you go first.
Well, just to touch on translation more broadly outside of, say, VA, the findings from many of these initiatives are relevant, and also we are developing tools. For example, Storm and ReachVet are both are publications with full covariates, how to rebuild them, and with even this bias analysis work, we had released with our FDA partner an R package, which is an open source statistical modeling language. And I do see us also providing our value sets for these social determinants of health and other products out of that work, open sourcing them.
Yeah, so the thing that I would highlight that has really struck me over my time at VA and maybe reflecting more broadly is the cultural and structural bits around data and data management, that normally data and data management are considered maybe second tier kind of things. And what we're finding in our strategy and the work we're trying to do is that we have to find a way to elevate the focus on data and data management and not sort of come to it after the fact. So that's kind of I think something that would be a translation, a lesson learned that maybe is applicable more broadly.
Great. Adam.
Hi, this is a question for Shamendra. This is Adam Studley. I'm a clinician and researcher at the Minneapolis VA, and we're in an interoperability conference. So, and we're talking about suicide prediction among veterans. The models that Suzanne described, like ReachVet, are a giant step forward, but they tend to take relatively static characteristics of a veteran, like we know they have bipolar disease, or we know they live in a rural area, to predict their risk. Outside and inside the VA, other kinds of research have shown that employment issues are a major risk factor in a much shorter term. When things go bad at work, the risk of suicide goes up, and that's a much shorter term phenomenon. It seems like a structural issue that we face in the VA in trying to do something about that clinically or do research about it is that the veteran may go to the VBA and say, I'm no longer employed or I don't have income, and talk about benefits, but that may not end up over on the health side in the electronic health record. And then when we're trying to, as a clinician, find out who's at risk, or as a predictive analyst, incorporate that, we can't get it from the VBA side. Is there a plan for addressing that?
Yeah, that's a great point, and it goes to some of the internal stovepiping issues, and the legacy IT, and some of the challenges we face. A big driver for the data summit that Amanda and I talked about was the experience that while we were doing a lot of data sharing around suicide prevention, including sharing some of the kind of call logs and from call centers and things like that, looking. Those were not being shared broadly. They were point to point, right? They would be shared into a research program or a clinical program, but then somebody else couldn't get access to it without restarting the information sharing. And an obvious thing is, as a CDO, if we do one point to point information sharing agreement, can't we use a template so that a second one might be 70% the work, a third one might be 50% the work, right? That kind of process improvement around information sharing requires work on data policy, right? It requires greater transparency. So those are the kind of observations that led us to that data summit. Now we, out of that, have a pretty rich set of findings where we have a group of individuals working on a top clinical priority, suicide prevention, that have agreed to be the use case, the guinea pigs, right? Why? Because they need it for their own work, but we think we can leave something behind for VA more broadly, right? If we can tackle these systemic issues through that kind of second level thinking. So the answer is yes, that is exactly the kind of thing we're trying to work on. We're trying to fix it systemically though, not, looking at it, point to point, and that takes a little bit more time. But that's the journey we're on.
Makes sense, thanks.
And thank you. It's great to have another VA person on, so I appreciate the the VA cadre that's on the conference.
Lorene, I think you have your hand up for a question.
Yes, these are great presentations, Paul and Suzanne. Thank you so much. So Suzanne, I'd love to hear more about your efforts to sort of extract SDOH measures from EHR records in the VA, and then the possibility to supplement with other outside data, have a richer set of features.
Yes. So what we're calling ReachVet 3 is planned to integrate more of the NLP-based predictors, so the social determinants I mentioned earlier, and those are individual level. But I'd love to move forward a next version more around area-based predictors. I think some of the work, say, you're doing, Lorene, but thinking about, whether they be social determinants or perhaps even integrating environmental data such as altitude is associated with suicidality. And these are ongoing conversations. So definitely next steps.
Great, thank you. Excellent work.
Oh, Paul has a question about SDOH screening. Is it done universally?
So that is a very complex question. The answer is no. And it's, you know, and this often comes up with extracting clinical concepts, especially from unstructured data, you know, more of the patient notes. It is dependent on what the, you know, provider is, you know, asking and documenting, you know, but there's many of these issues that riddle EMR data, you know, even many patients for which the VA would, you know, really love to reach out and engage more, are often the ones that are, you know, not receptive to it. So unfortunately, we don't have financial data where everything is sort of regularly sampled and, you know, you sort of get this day to day or even minute to minute type of data stream. You know, there's a lot of observation bias, although, you know, I think we've adopted the principle where if it's there and we can leverage it and we can validate it and the clinicians find it useful to their decision making, we should use it.
Could I ask you a question? I'm not sure to whom to address it, but I'm interested in whether you're incorporating the use of Z codes in terms of tracking SDOH and encouraging your VA providers to put in those Z codes as they learn more about the patient. And second, if ReachVet is coordinating with Be Connected, which has been very active here in Arizona.
Shumendra, do you know the answer to those questions?
I don't. Amanda, do you know?
No, not to my knowledge, but I'm happy to do a little digging.
Yes. Well, we will get back to you, Eric. Great questions.
Okay, thank you. You'll find the Be Connected program is incredible. It started in 2010 in Arizona when the Air National Guard, or sorry, the Arizona National Guard had the highest suicide rate in its history. They brought this program in, and within 2 years, they went to 0 suicides. It's incredible. And they've been nationally recognized. So I think it's really worth taking a look at. So if you want, you can certainly connect with me. I'm in the speaker bios, and I'd be more than happy to get you connected with the right people.
Excellent, thank you.
You know, I would highlight along those lines that there is a real focus on something called M2C readiness, military to civilian readiness, looking a year prior, a year after. In the last couple of years, we've instituted with our partners in DoD training, which is new for every departing service member, right? A week-long training, and we're currently working on a pre-qualified statement of benefits. Air quotes on pre-qualified because it's not valid till they retire, and there may be some medical exam things, but trying to get the veteran kind of set up and have a solid transition. And then on the transition side, we have a program, Solid Start, where we outreach 3 times in the first year just to check in, right? So even though we're focused around choice, we really want to make that choice meaningful by systematically engaging with service members and veterans. And that program has, I think, paid a lot of dividends, and because that transition time is a critical time for policy interventions. Over.
Daniel, can I ask a question, please?
Yeah, oh, sure. And we can finish up there, Tony.
Yeah, this may be completely off the wall, everyone. I'm sorry. I was in court for a few minutes before we started. This is great information as it relates to veterans and the uniqueness of what you're doing to try and assist. I'm wondering if the information that you're learning is transferable. I mean transferable to children. There's a serious problem with suicide rates with teenagers, adolescents. And so although I know this seems to be very veteran focused, can the information in any way, or is anyone looking at using the information you're using to try and recreate or focus on the juvenile problem of suicide rates in the country? Working with OJJDP or working with, Health and Services, any other departments of the feds to focus on the challenges of suicide rates for children?
So, the answer is there is an effort along those lines. It's the Prevents Task Force. So this is a White House task force that started a few years back that was looking at suicide prevention more broadly, focusing in particular on community-based approaches. And part of their DNA is the idea that, what we're doing with respect to suicide prevention for veterans has legs and should be anchored in community-based activities that are looking at suicide prevention more broadly, right? That could potentially include juvenile populations or other at-risk populations. So there is an active body of work that aligns with what you're suggesting, and we could reach back and try to help make connections for that.
Thank you, Shmender. It's good to see you again. I haven't seen you in a year or two.
Thanks, Tony. Thanks, Shmender. Thanks, Suzanne, for really stretching our thinking here on capabilities and possibilities around interoperability at scale. And I want to thank you for taking time out to share with us some thoughts on this. We will, as you can see on the screen here, we're going to take a short break for about a little less than 15 minutes. If folks can come back, we'll then use the Zoom magic to break folks into groups. And based on yesterday's experience, I think we need just a few more minutes for folks so we can move you into the preferred groups. So when you do, if you haven't yet thought about it, there's 3 options to choose from here. One is the governance and consent management, a new idea around a utility around that, which is very exciting around how to manage consent. Housing is healthcare, with very concrete on the ground applications in Los Angeles, Arizona, and New York. And then our international panel on care coordination outside of the US, and to see what we might be learning from, we might potentially be learning from outside. We touched on some of those conversations yesterday. It is an interesting moment in time in our history, and perhaps our learning can be expedited in some ways across the seas and across the borders to the north. So what we'll do is as I said, we're just going to leave the Zoom on. We've got a little background music we're going to put on, and now is a good time to stand up, do some breathing, and we'll see you back here just a couple of minutes before on the East Coast, like a little before, around 1:40, 1:42, something like that, so we can just jump right into our breakouts then. And again, thanks for everyone. We will help you get into the groups. It'll be a self-choice, Matt. When we open up the breakout rooms, you'll be able to move yourself into the room you choose, or we'll help assist you in that effort. Okay? See everybody in just about 10 minutes or so. Thanks. Great. I think everybody should be back now. We're going to now do the magic of Zoom breakout rooms. Do we have that last slide we can put up one more time for folks who are just still making a final decision? So there are 3 groups. What we're going to do is we're going to, we've got the leaders pre-assigned to the groups. Hopefully they'll, when we actually divide you into meeting rooms, the leaders or the presenters will be in your room. Everybody has a slightly different version of Zoom, so the instructions we've discovered are not ubiquitous to everybody. So just have to see what happens to you when you get broken into a Zoom breakout. What will most likely happen is you'll go into the room and you'll have an option that will say join a group. You'll see the 3 groups that we've identified up here. You should just be able to hit join and automatically join that room. If you don't see that, sometimes another version of Zoom has a little number next to the unassigned. There's a little number of people who are unassigned. If you click on that, that oftentimes will allow you to join as well. So first, you can just join directly. Second, if there's a little number. And thirdly, if you don't see anything and you don't see a menu bar at the bottom that allows you to click breakout rooms, in the main room, what we'll do is we will just move you into that room, and we have the power to do that. What we would want you to do though, is just put in the chat the name of the group, either governance or housing or care coordination. And then we'll know from who's left in the main room who we need to move in. So this could just take a few minutes, I think. Michael, are we ready to do this? Mike, are you got the controls here ready to send us along?
I believe we're ready to start. Michael, how are you feeling?
Sorry, I was on mute. So I had to jump on my phone. Yeah, we're ready to go.
Okay, let's give it a shot. And here we go.
All right, everyone.
Okay. We are way.
All right, everyone. So if you are not in a breakout room and can hear us, let us know which room you'd like to go to, and we'll start placing you there.
Okay, I've got Leslie.
Great, thank you, Leslie. Diana wants to go to housing. Got you. And again, if you click the breakout room button at the bottom of your screen, you are able to select which room you'd want to go to by hovering over the number next to the name of the room you want to go to.
Arena. Someone's way ahead of me here. Okay. I'm catching up.
Wants to go to
Dawn. Judge. I will move to governance.
Don Hunter to lessons abroad. Paul Nelson, where do you want to go?
Please put it in the chat.
All right, so we still have a few people left. In order to get into a breakout room, you can just click the breakout room button at the bottom of your screen and hover over the name of the breakout room that you want to go to. Next to that, there is a little number, and that number will turn into the word join, and then you can click that. Otherwise, you can put in the chat where you would like to go, and we can send you there, or you can unmute yourself and just let us know as well. All right, Leslie, no problem. Where do you want to go?
Still waiting to hear from a few of you. Paul, lessons from abroad. Okay, I've got that.
All right, Leslie, I'll take you to lessons from abroad. There we go. So we still have Carly Beck, Chris, Christine, David, Gary, Paul.
Vernon, if you could move me into the utility. My chat's not working either, besides not being able to move into the chat, into a room.
You want to go to governance?
I just moved in there.
All right, thank you.
How about other folks? Are they just, maybe they're just not back yet?
It's possible.
That's possible, yeah.
Dave Alliard, you just joined. Where do you want to go? Which group?
Your group focusing on governance of rights.
Got it. Sending you over there.
Thank you.
Chris Tappan, are you back with us? Chris Gibbons? Leslie?
Carly Beck? Lisa?
Probably just not rejoined. We can, Daniel, if you wanted to embark, we could handle the rest.
Great. Okay, great, guys. I just used the teams to, surprised Paul isn't there though.
I am not sure we ever saw Alfonso show up. So that's a slide presenter who's missing, right? Is that a problem?
Maybe. I'll send him a quick email.
All right, I'm direct messaging a few people. Hey, Stacy,
Oh,
which room would you like to go to?
Alfonso just joined. I'll move him.
Oh, did. Okay, great.
Yeah, so did Stacy.
Hey, Tona. I got kicked out of Zoom when I tried to join Breakout 1.
Is that governance?
Yep.
All right, I'll move you there now.
Thank you. Hi, Daniel.
Hello, Stacy. Lisa Rika, are you on with us? Can you assign people to groups that they're not in?
Yeah. Yeah.
I'm gonna move her there.
Okay, so I sent the 5 remaining people a personal message to see if what room they want to go to.
Thanks.
And Daniel, we have it under control if you want to move over to governance or.
I'm going. I'm leaving.
He likes the feeling of power, moving people around.
Stacy's still here, I think, though. Stacy, are you moved yet, or?
I believe that's just her image, but according to the breakout room process, she's gone.
Yeah, that's odd. Usually that goes.
Yeah.
Okay.
Verizon.
I'm going away.
Oh.
2 new people in.
Hi, sorry, I'm gonna go back over to the abroad session. For some reason, my Zoom wasn't working. So
I got you. No worries.
Can you guys move me into governance? I'm not. Oh, maybe I got to go a different way.
Yeah, because you're not showing up as unassigned. You're already like you're in something.
He's gone now.
Gone now. Yeah.
Okay, so we have Chris, Paul, Matthew, and Lisa. Great.
Oh, I forgot about the what kind of timing we're looking at here. The 2 breakouts go till 2:45. Yeah, 2:45 Eastern, 1:45 my time. Hello,
What?
Donna?
Yeah.
Oh, you are. Okay, you're there. Yeah, my audio's got awfully quiet all of a sudden. I was getting some weird static.
Who's sharing their screen? Paul Nelson is sharing the screen.
Okay.
Why?
Okay, I can stop that.
And then
Unless you
Stacy
really
got
wanted it.
again.
And Stacy's hanging. Yeah, I think she's got some telecom issues, not getting in.
Hi there, Tona. Are you there by chance?
I am. Hello.
Hi. So I keep getting kicked out of Zoom, and when the breakout room connection doesn't successfully happen, it asks me to join by browser, which then shuts down all of my Zoom options and says error message timed out.
Okay.
You want to try using phone connection?
I can certainly try that. I'll hang up and dial back
Great.
in.
Yeah, when we see your phone number come in, we can move you in the room. That might be the quickest way.
Okay, I'm gonna hang up and dial in by phone.
Or do you want to try it one more time while we have you here, just in case?
Sure, I can manually try to put myself in.
Whose screen is that? Still Paul. Okay.
Paul, what's happening? If you can hear us, let us know what room you want to go to. Oh, maybe he's trying to show us that it's not working.
Oh.
Well, I just need to go to a room.
Yes, which room do you want to go to, Paul? We can assign that for you.
You know, it really doesn't make that much difference to me.
Okay, then I'm going to put you in housing and is healthcare. Is that all right?
That would be perfect.
See you later. That was funny.
Yeah, we probably should have stopped his sharing before we sent him, but I'm sure somebody will inform him if
I
it
did
pops up in. Oh, you did. Thanks.
Yeah. Yeah. That would have been weird.
Stacy looks like she's back in the room with us.
Well, it's weird. I think it might be crashing again.
Yeah, the connection's just not happening, huh?
Because I'm looking at, well, it says here that she's in governance.
Yep. Her image just disappeared. That's a good sign, unless she got kicked off the call again.
Yeah, let me jump into governance and see if she's actually in there. 1 second.
Okay, thanks.
It's unclear.
Okay. I just lost my video and audio as my puppy just chewed through the wire of the cable coming out the back of my PC. That's a new one.
Dang.
Bye-bye.
Yeah. Okay, bye, everybody.
Bye-bye, Dave. Thank you.
I think we're all back, more or less. Michael, are you there?
Yeah,
Our
we're back.
here. Everybody joined us back here again.
Yeah, the
great.
rooms are empty.
Well, hopefully we won't have another year of having to practice Zoom and get our technology in order here. Hopefully that will alleviate the need for that, except for on occasion that we want to use it. I think that I was able to join some of the sessions and listening on the conversations. It's awfully difficult and challenging to sort of bounce around between sessions, and they're all interesting. As I noted in the past, we're recording. I believe we've recorded all of them, and I know that everybody probably had multiple choices for wanting to join different groups and to hear different groups participate. And so those should be available very soon. So you'll be able to binge watch or binge listen on those particular sessions, which we'll be posting and letting everybody know who's been participating in this. So we're moving now into into the sort of the final discussion session, and we're really looking forward to having a conversation about the power of collaboration, kind of like what Dave was just talking about. and the work that he's done, which he may have mentioned around the world, really bringing this very similar vision to the world platform, the world stage, is very encouraging and exciting to know that there's interest in we're on a pathway that intersects with the developing world and other parts of the world, from our international folks to our local and state and federal partners here. So we have a session now. Unfortunately, I think we have a couple of technical challenges that I may have inhibited a few people from joining today. I don't know. I know that Clara, you're here with us, right? And Charlie Brunner, you're both here with us.
Yes, I'm here.
Great. And Clara, I think you're here with us as well.
Here.
Yeah, great. Thank you for that. I got a message just a little while ago from Laura that said she had some emergency situation, and I am wondering if Shoma has joined us. I'm wondering if she is caught up in the issues with connectivity that I know a bunch of people are experiencing. So I'm not seeing her. Just try to connect with her via phone, all the various possibilities. So I'm sure she would be here otherwise. If she's not, maybe she'll be joining us soon. So this session is going to be modified a little bit, although we had intended it always to be really an opportunity for everyone in the room here to really join the conversation. Each of you really represents a part of the work, segment of the work, multiple segments of the work, and that each of you are operating and interacting with different networks, whether or not they're legal networks or technical networks or all sorts of different ones. And as I've said in the past, the tendency is to stay in our silos and to stay in our lanes. And we know that there's power in that, but we also know that there's challenges and lost opportunities from not collaborating further. And so the intention here was to talk with some of our partners who are actually have been along the route with us here. And so what I'm going to do is I'm going to actually ask others, and I've already asked some other folks to sort of weigh in on this conversation. Just a couple of thoughts as we move into this conversation here. And one of those thoughts is to keep really in mind is that we're still in the midst of this pandemic, and so much of the work that started this initiative, the National Action Agenda, has to do with the fact that the pandemic has really changed our view of the world in terms of exponential growth, exponential virology, and it's changed the way we think about scale, rate, and scope of change in the world around us. I think if there's one tiny silver lining in this, is that maybe people have now begun to understand what exponential means for those of us who are not paying attention in high school trigonometry or calculus. It's a bizarre and frightening concept, and so the challenges that we face are in fact exponential in nature, given that it's a global pandemic. And so as a result of that, we need to think differently. And I think that's part of the idea of this idea of collaboration. I showed these slides at the very beginning of the work we were doing because it felt, especially in the grip of going into something which we really didn't understand fully, that we have to do it with an equity lens. And there has been so much harm generated over the years and decades and centuries from the oppression and from all of the challenges that we face. And I think and I think there's a sense of that in this couple of days we've been meeting around really thinking about justice and equity and keeping our promises and, being nice, just being nice. It's a challenging world out there, and how do we approach our work in that way? I think it's really important. And this last idea, which I think many of us have seen in the past, is if you want to go fast, go alone. But if you want to go far, go together. I think we want a hybrid, which is we want to go fast and we want to go far. So we have to create something new. But one of the ways to think about that is really through collaboration. And throughout the process that we've gone through so far, we've had a number of different organizations participating in this work, or we've been participating in their work. And some of them are listed on here. So Data Across Sectors for Health, Claire Tenner is a co-PI in that, who's with us here today. The folks from the Gravity Project, who I don't think Evelyn is with us here today, but they're developing codes for being able to standardize things like food insecurity and housing insecurity, and are working broadly across the spectrum. We're involved with their on their executive committees and technical committees. The Foresight group, and that's Laura Landy, who I don't believe is going to be able to join us, we heard from Stacy Chang yesterday about the work that they're doing really around trying to not only envision the future, but actually build towards it. HIMSS organization, which is a giant, healthcare IT association, has been involved and collaborating with us and driving the message through health IT. Has been encouraging because the last couple of years they've really been starting to adopt and trying to understand social determinants. And as the driver in that field from an association perspective, very powerful. The WIN network, the Wellbeing in the Network, Wellbeing in the Nation network, has just done outstanding work, really conceptualizing social determinants, putting organizations together, and encouraging the kind of work that is. Okay, so great, someone is joining us. Michael, if you, she's looking for the ID. I'm gonna forward this on to you. If you can, excuse me for one moment here while I do a little bit of meeting management. One second. There you go. Mike, if you can confirm that you can send Shoma the meeting ID information.
Yes, I can do it.
Okay. So finally, the ink marks work, and Charlie Brunner, who has been participating in that, has been participating in the work with the National Action Agenda, and has really partnered in many ways with us around the letter to the administration, around looking at the ability to really put kids at the center. And Charlie has been just a consistent, loud voice and a strong voice in that area. So when I look at those organizations, what they're doing individually, it's robust, it's exciting, it's interesting, it's also recognizing that if there were ways to lift up each other's work and to connect the work so that there's less duplication, how much farther we'd be able to proceed. And so with that, I want to send Shoma the Zoom again so she can join us, and then we'll get started on the conversation here as she joins us right away. I'm going to actually put you on hold for 1 second to see if I can connect this with.
I just sent it, but
So here we go. Shoma, welcome. Thank you. I was just talking about, I was just sort of setting the context for a community of networks, and Charlie Brunner's on and Claire's on. Laura had an emergency that she was not able to join us for, so so we have an opportunity now. We've just obviously are sort of bringing the conversation into this idea of better a better sense of collaboration across a community of networks. And I've been describing the work a little bit of what WIN was doing and Dash and Foresight, and are just now launching into that conversation. So I was just going to ask you and Claire and Charlie just to say a few words about where you're at, and then dive into the conversation, and then we'll open it up more broadly for the sense of collaboration. So welcome, and thank you for joining us here. If you'd like to just say a few words, that would be great.
Sure. Hi, everyone. It's such a pleasure to be with you all, and I apologize for my technology mishap today. That made me late to come to be with you. I think this work of bridging across our networks, we can see how it's so critical, and yet the enabling technology that makes it easy just isn't there. And the way that I liken it is to say that, I remember in my early days as a primary care doctor at Cambridge Health Alliance, we all believed that when a patient showed up in the emergency room or had an issue at the school or social services, or that everybody should know about it. And we would exhort people to talk to each other. But the thing that changed everything was when we built interoperable, simple notification systems, so that the minute my primary care patient crossed the ED, got transitioned, a very simple note automatically came to me. And then, and that would happen not just with hospitals in our system, but we were able to build it so that it happened across other hospitals in the system with just enough information for us to know what was going on. And then it got better and better as we actually built EMR systems that made the right information come to me at the right time. And suddenly you had all kinds of collaboration develop that hadn't been there before. Now, this was just within the healthcare system and not within the context of everything we know is needed for social services, early childhood, and school support. Those were all manual systems that we actually jiggered our base data systems to notify the school nurse, and the school nurse to be able to access the kids registry, so that everybody who needed to be part of supporting a kid to stay in school and not be in the hospital and emergency room, and not be even in the primary care site necessarily with their asthma, but to stay well at home, that everyone had the access to the right data systems to be able to help support what was the primary goal for that kid, which was to have a good life and to stay in school and to graduate from school. But really what I learned was how powerful enabling data systems were to make it possible for collaboration to happen. And I think we're at a place now where we all recognize that we need to connect across the determinants of health. We need to connect across health and social and schools and all of the sectors that actually touch a person's life. But because we have historically seen these as silos, we have built no systems that make it easy to connect the dots. And I think the work that Stewards of Change and others are leading and advocating for base connectivity infrastructure that's person and family centered, that's equity, that has an equity lens to assure that the kids and families that most need that coordination have the benefit of that coordination in a way that works for them, so that they're not managing 15 care managers from different agencies that have been assigned to them, but rather are focusing on the things that matter most to them, which is to be able to live their best life with the coordinated set of supports. I think we're learning how important and critical data infrastructure is to support that. And so I think from our perspective in the WIN network, our fundamental goal is about how we advance intergenerational well-being and equity. We know that to do that, we need to, on the one hand, set our sights on what really matters to improve intergenerational well-being and equity, and that's measuring differently in ways that matter to real patients and families. It's about having the connective infrastructure to enable that, and it's about addressing the root policies and systems that perpetuate an inequitable economy. And those are economy and an inequitable system. And so as we think about this work, we see the work that is happening here that's stewards of change, and so many of you are leading is crucial. We would love the same interoperable systems to know what our networks are doing. Wouldn't that be an amazing thing for that information sharing to be natural? And we are in support and stand with anyone who helps to create that ecosystem that helps our families to thrive, especially those who are most affected by inequities.
Thanks so much, Soma, for starting us on this conversation. I know that Claire and the work at DASH are very much in alignment with that. And I'm interested, Claire, from your participation in the NAA since the start here and the last couple of days, how you guys think about collaboration within DASH and kind of where we can head with that.
Sure, and really pleased to be able to participate in this collaborative endeavor, including leading up, helping work with you all and leading up to the meetings of this week. So just for folks who might not know about DASH, DASH, or Data Across Sectors for Health, is a program of the Robert Wood Johnson Foundation. And the Robert Wood Johnson Foundation has essentially contracted out the program office to a collaboration of the Illinois and the Michigan Public Health Institutes. So I'm here in mid-Michigan with MPHI and serving as co-director of DASH. I used to say, along with Peter Eckert, my friend who just resigned and is doing more wonderful things, but I will have a new co-director soon from Illinois Public Health Institute. So DASH does a number of things. We re-grant Robert Wood Johnson Foundation funding to communities and community state collaborations to support multi-sector data sharing. Our programs have reached about 150 communities. And they're designed to span the gamut of experience. We have menteeships that serve as an entry point to support community collaborations that are just starting to plan their data sharing initiatives. We have cohort grants to provide targeted support and technical assistance to existing community collaborations working on data sharing. And then now, most recently, we will soon be announcing our community state grants, where the aim is to understand how states can support data sharing and collaboration at the local level, and also test a path for scaling through state level investment or policy. So we collaborate with about 7 other program offices to support a learning community with over about 2,000 members, which includes an online community, includes a national meeting, webinars, even peer-to-peer site visits, sometimes regional meetings, back when we met. Right now, virtual meetings for sure. And we, early on, when we were developing this collaboration called All In Data for Community Health, we asked our co-conspirators, like, what should we do as part of All In versus what should we do as DASH? And we eventually reframed the question, why don't we ask ourselves instead, what wouldn't we do together? Now I realize I'm saying that, and we have the All In network that I said is already a collaboration, but also the Stewards of Change has an amazing network. WIN has a network, and so I am sensitive to the challenges, and we participate as DASH in as many as we can, but it does offer an opportunity to think about exactly how much time am I spending on collaboration, just to make sure we're staying on the same page and not being duplicative. It's important work, but it is a puzzle, and I look forward to hearing how other people address that. But just to finish, round out the description of DASH, we are engaged in efforts to curate the information that we are now amassing from these 150 communities and thousands of members, so that we can better synthesize and translate what's being learned. and certainly hope to bring the assets that we can leverage to conversations like this one, and participate and contribute.
Thanks.
Yeah, that's
Yeah, it's been wonderful to watch and to be able to interact with Dash and All In as we've been developing the NIC network and gotten to know Soma over the last couple of years, and the network that the WIN network offers nationally as well. So sort of the juncture, the overlapping benefits of those are really quite significant. Charlie, we've talked in the past about how to collaborate on benefit of children in particular. In your work over the years, and most recently with Integrated Care for Kids, offers you a sort of a unique vision, both from the foundation world, from the legislative world, from government world. Do you mind saying a few words about how you view this collaborative spirit?
Yeah, thanks very much. And I say I bring really three dubious backgrounds to this work. I did get a PhD and did a little teaching, so I have some academic bent. I served 12 years in the Iowa General Assembly, so I've been a politician. And I established my own policy center that later really engaged in a lot of advocacy, so I've been a lobbyist. So I've kind of brought those different perspectives to this work on the kind of fundamental question of how can we succeed with kids that current systems fail. And for the last 5 years, I've really done a lot of work around the healthcare system, starting with a grant from the Robert Johnson Foundation, which we talked about health equity in young children, and really looking at the leverage point of responding to children and their developing needs in the context of their families to achieve health equity, and really our youngest children. And then I was asked by RWJF if I would be willing to provide some support and guidance to states and communities who were thinking about applying for the CMMI grant. And I think RWJ was aware that I had lobbied and bugged the Center for Medicare and Medicaid Innovation to do a federal opportunity announcement on kids. And they did come out with their Integrated Care for Kids initiative. And so they supported me in putting together kind of a loose network and trying to pull together materials that would be helpful to states and communities in thinking about that grant, and subsequently have provided me ongoing support. And we have a network of about 35 different organizations and a national advisory team. And we move beyond just the Inc. model to really looking at child healthcare transformation. And I think one of the themes that we have is that really we are in the process of moving from a medical care system to a healthcare system, to recognizing and trying to respond not only to medical needs and medical complexities, but also to social and relational complexities. And we actually have the field through the emphasis on a patient-centered medical home, and through Bright Futures, and through other work, and a lot of exemplary practices, which are really working to move primary preventive practice as well as more intensive practice for people in need to a broad model. And this does entail reaching out to and working with other systems and responding in the child health system, but it also does require the child health system itself to be operating in different ways. And the discussion guide question, what your current efforts benefit from more collaboration? One of the things I do want to raise here is I think the most important collaboration for being effective with children and families is the collaboration between whoever is meeting with the family and child, and the family and child, and that we really do take an asset-based valuing approach, that we establish a level of trust. And then as Soma said, that we work from where the family is and what the family hopes for its children in order to succeed, and building this kind of frontline practice or assurance that there's continuity and relational care provided is really key to developing then collaboration and then holding other systems accountable for being themselves more collaborative and responsive. In terms of the Inc. model itself, and in terms of a lot of the work that we've been discussing here, we see that there are, and we don't have firm numbers on it, but probably 3 to 5% of the population of children are multiply involved in systems that are doing some form of remediation, response, treatment, work around an identified need. And it could be a really major social complexity like involvement in the child welfare system. It could be a major medical condition or a very significant disability, but those kids are often in multiple systems. And the challenge, one of the challenges is to have more interoperability, but it's also that those systems to be more responsive to where the family is and what the family's need are. That's where the Inc. model itself focuses its attention. There are another 25 to 30% of the population which kids are not doing as well as they could, certainly. They may not have major presenting medical conditions, but their prognosis in terms of their healthy development, social, physical, psychological, and cognitive is in jeopardy. And those need, and I think can benefit from that frontline work that is more relational in terms of care coordination. And so we're really looking at how can we embed that somewhere in systems as well, and make sure that we have a better reach out and that there is someone who has established some level of trust and understanding with families who can serve in some form of care relational way in terms of navigating systems and enabling families to speak out for themselves to get what they need.
Right.
And frankly, you know, I'm hopeful that as the new administration takes off, that they will both advance work around kids who are multiply involved in systems and for whom interoperability and collaboration across existing systems is important, but we'll also look at a way of doing this collaboration with families from a more preventive developmental perspective.
Right. So let me open up the floor a little bit here. You know, one of the things we've talked about, one of the questions I have actually haven't shown yet here is you know, pragmatically, how can that? What are the benefits? What are the needs of being able to collaborate? And one of the things that we've been focused on is actually the technical needs, the actual connectivity to enable the data sharing to occur at the level of clinical practice. There's certainly a ton of stuff going on with de-identified aggregate data and policy information, research, all really useful, great stuff. The question that came up in big way was, how do we actually bring that down to operational level? And how could we, through collaboration, actually make that happen so it's more effective, that everybody's not having to create those solutions themselves? So I put that question out there and ask if there's a response there. I know that, Christine, we've talked about this quite a bit in terms of, can we do stuff in Inc. that could be valuable and useful elsewhere in other organizations, other Inc. sites, and other jurisdictions?
Yeah, I think that there is such an opportunity. And I have to say, in my experience, asking people to come and collaborate for its own sake rarely works. Asking people to come to collaborate to solve a problem that no one can solve alone works really well. So some examples that I can think of right away that from just the last couple of years in Delaware, actually consolidating the data across 2 systems to actually show that as kids who are some of the highest risk, who are graduating from foster care, juvie, and or experience of juvenile detention, and who were in the active kids mental health system, were not making it into the adult mental health system. And in fact, it was such a dramatic fall off. It was shocking. Help people see, A, there's a problem, and B, that we need to connect the dots across those. And that required initially bringing together in a manual way all of the leads of those departments and the care managers working with the youth to proactively say, well, who's going to turn 18? What would success mean for us in a simple care plan?
Don't stop
They
now.
have a care plan, like super simple. They're connected to a path to education or career. And as they did that, like as you actually literally took every child as a PDSA of like, what would it take to support this child to thrive? What were the policies that were getting in the way? What became initially a manual registry-based data sharing effort, looking at these 12 kids are going to turn 18 this week. What do we need to do to assure a successful transition? Where do our own policies get in the way, which require a policy exception? And then what does that mean as those build up to create longer term change in policies across Medicaid and social services and juvenile detention and the kids department and adult substance abuse? And then that led to the creation of universal consents, a common care plan, and something that could actually cross as a bridge across agencies to support the transition, and then a regular process of quality improvement. Similarly, as you're during the pandemic, we were able to accelerate police diverting from people with mental health and addictions ending up in emergency rooms and booking right in, to instead have them be diverted right into mental health treatment. And what the police needed, they were willing to do it, but they needed an information system with close the loop. And they needed to know that, hey, we referred these people in our lay system. So they actually built the system right into their existing workflow and system, but they needed to hear on the back end what happened. And that meant making sure that there was a system that received each family, assessed where they were, and closed the loop, both to know that they had actually gotten into care and treatment so that people could leave their sense of ownership behind for what happened with that individual, that they had met their obligation for safety in the community by providing both the safety of the individual and the safety of the community, which also meant that they could decarcerate in a state that has a much higher rate of Black people being incarcerated than other groups. And so, and then similarly, coming out of incarceration, being able to assess and know quickly who was going to be in trouble, what their needs were, who was at greatest risk of suffering, and then being as a whole person being able to meet that need. And so data collaboration was really in all of those cases driven by real challenges people needed to solve, which overcame the change resistance to collaboration itself, of working out the difficult pieces of your policies, your agreements and workflows, and was met with and was again supported by some innovative leaders who are willing to fund the base infrastructure cost of that collaboration, not just the collaboration cost as well as the infrastructure cost.
Yeah, it's impressive work in Delaware, and the way you've embodied that work in WIN. And I think that idea of, you know, and to Claire's point, sort of collaboration to what purpose? I think that's really an important operational question. Where, as I said before, where we've come at this now is, can we bring a national collaboration together around data sharing to be able to share practices that are more open source, more open standards, and that could actually drive change. So we don't really require all systems, all jurisdictions to actually have to figure it out themselves.
Daniel, if I could make a comment, one, I just love listening to people like have just been speaking because I learned so much from it. Number one, and two, feel better about the world. I think one of the things that rather than looking at lack of collaboration as a personal failing in people, I think we need to ask ourselves, why don't we collaborate? Because the banks in the country, in the world, are not the friendliest of people, and yet they've figured out how to collaborate to share financial data so my ATM card works in any country I go to. They got together to collaborate because it was a business driver to do it. So when we look at the failure to collaborate and why we have silos, I think we can look at three different things. One, there are not financial incentives for it. As Simone was just saying, the people who will pay for collaboration are few and far between. There is not an incentive to do what Charles just said for the most part. There is not an incentive to bring people together. We don't pay for that collaboration, but more importantly, we don't pay for the second point, which is the goals are transactional today. We pay for transactions. We pay for visit me at the FQHC, visit me at the office, pay me for the operation, pay me for housing, pay me, rather than what Charles was just describing is the longitudinal development of a child to some higher goal. And so we've got the finances wrong and they're in the service of the wrong goals. So why should we be surprised that we don't have collaboration? So if we change the goals to what Charles described, legally change the goals, that what we will pay for is the successful development of children, that forces collaboration, because you can't have a child thrive without the collaboration of all of these forces. And people want to make money. Not everybody runs to the incentives that the people on this call do, which is, we all create models of not being for profit all the time. But most of the world doesn't work that way. And finally, habits are really hard to change, even when we change the incentives. And doctors are trained to be the captain of the ship. So you come along and say, no, actually, we're going to collaborate as a team. And the doctor says, excuse me, for 30 years, I've been the captain of the ship. I don't want to change. The COVID gives us a good opportunity to number one, get money to force collaboration, and two, to smash down some walls.
Thank you very much. I think that's true. Other thoughts?
Thanks, David. I really appreciate those comments and Soma's comments as well. And I know what Soma does is not only the integration of plans, but to do it with a certain mindset around what children and families can achieve. And I sometimes say it takes a village to raise a child, doesn't say it takes a multidisciplinary team of a child development specialist, a social worker, and a counselor to raise a child. That even when families have multiple problems and multiple concerns in their issues, they often can succeed, but they're going to require more than just professional services and care to do so. And obviously, family voices and other groups have really taken the ticket. Don't make decisions about us without us. There are, in the child welfare system, family group decision-making and family team meetings, which employ those who are involved professionally with people, but also those extended family members who need to be there to provide support, or circles of support planning for kids in the disability world who are reaching adult age. Who's going to be there for that part of that family and community for the child? Or foster youth support groups that really are more in the way of peer networks. I do think that as we look toward this work and the how we can be effective by collaborating together, we really have to do so in the context of something that is really meaningful and where we gain as much maximum investment as possible from families, and that we do recognize their ecology and draw upon who is going to be there 24/7 in their lives and in their community. Not that the professional services aren't needed.
Other thoughts and comments? Nancy, your comment here, reminds me of this question around social determinants and where that should be located. And, sort of the medicalization of SDOH, whereas the need for greater collaboration, including medical, but not necessarily located in the medical community as the driver, as per what Charlie was saying as being the, or what we were just talking about a moment ago about there being, a doc who is in charge and relative to be able to address the social determinants feels like a major hurdle and a major challenge as we move more, sort of more directly into the world of recognizing social supports.
One of the things about this conversation, it's so tantalizing and yet semi-frustrating because I keep trying to jump to the concrete. So what do we actually do? We know so much about what the barriers are. I mean, we see how difficult it is for people on the ground to create this collaborative infrastructure to support the well-being of their community again and again, and they have to surmount a lot of barriers to do it. And so some of the things I'm thinking about are, for instance, the work of the WIN network, and and really collaborating and having this engaged process to sort of develop a shared vision and a set of metrics to say, hey, why don't we strive for this? Let's put it in the healthy people policy. Let's promote it as things that communities can line up with. So that's one thing that's really been one of the things that answers that question for me. And then another thing that we're trying to do at DASH, somebody mentioned the transactional nature of, here's the state wants services, pays this agency to do this service in this agency, and everything's very transactional. And one of the things we're trying to learn with DASH, because we see many inspirational stories of folks at the community level truly rolling up their sleeves and building and working on the systems change to take down the silos, as somebody said. But so we're funding our programs to encourage states to collaborate with community collaborations so that it's not the state interacting with one or two of their agents at the local level on this transactional basis, but the state's figuring out what sort of policy change would actually support that type of collaboration. And would love, feedback or ideas folks have. We're looking forward to at least learning along with our grantees and seeing what might be generalizable.
We're having great luck doing exactly that, Claire, is going into communities, small and medium sized, and trying to get around the table. The United Way, the primary care, the groups you're describing, plus the leaders of the most marginalized communities, and getting them to combine, but getting them to combine on a much faster timetable than they're used to. What we're finding is the people who want to do what this group is focused on of interoperability, a sharing of information, are on a long-term timetable. They're not on a, oh my God, we got a pandemic and we got to share the information right now timetable. And what we're encouraging people to do is to try to jump onto the new timetable and take advantage of the money that's flowing out of Washington right now, and hopefully will flow some more to accelerate this change.
Well, our proposal is if I mentioned it several times over the last couple of days, is very specific. And it has to do with, right now, the Integrated Care for Kids site in New Jersey, potentially in New York around consent to share, and a few other counties who have a strong interest in really looking at how do we technically connect the dots? How do we connect between these services and create that in a way that is open? It's a blueprint to others. And so our proposition is, let's do that. Let's focus attention, energy, resources to create that blueprint so that every other community and the other coalition can do that, as opposed to having to go create it by themselves or simply to go procure a end-to-end proprietary system. And I think that Dr. McCoy has been really leading that charge in a lot of ways. And the call to action here is to ask people to join that conversation, to join that work, either directly, indirectly through the work that's going on, and to figure out new collaborative mechanisms to actually support that, because there's some real possibility of taking that and actually exporting that to other communities and building out that resource that is very elusive at this point in time.
There are several comments in the chat as well as others that I think it's so easy to build systems based on our priorities, but actually the only orienting thing I've ever seen in this is to build it based on the priorities of families and those affected by inequities. And if we let who they are and what they need drive the design of the system, we're far more likely to get to something that's both effective and efficient. And when it comes to disrupting the system, I'm thinking about, way back in India, generations of farmers were struggling to have an equitable way to get their products to market in a way that they could get a good price. And really, once you spent a few hours getting your goods to the market, whoever was the purchaser had all the power. The biggest disruptor to that was actually a smartphone, satellite enabled, that connected in a text-based way all the farmers in the area who could show up at a place and quickly, the first farmer who got there, using WhatsApp, texted out to everybody else what the price was. So that scouting enabled by technology, this is a hardwired thing, not a naturally interoperable thing, but this was something that utterly changed the balance of power in terms of farmers being able to negotiate better goods so they could then actually afford to do the things that they needed for their children to stay in school and their families to thrive. And I think the extent to which we can drive our focus on what communities experiencing inequities need, using like the 5 whys, not just there's what they say they need right now, and then with them thinking about the whys, and how do we disrupt those underlying whys and invest with enough duration and dose and enough time, as Tyler Norris would say, to actually interrupt the cycle of poverty. And I think it's that kind of frame shift that we need to begin to adopt. And I absolutely agree, David, that changing the payment and what we're accountable for is a part of that, because that needs to be the enabling shift in our mindset toward well-being. And in my experience, like that can end up in gatekeeping or other kinds of things if that's not enabling of a larger focus on how we drive systems of equity. And so I'll just.
One of the things we should really worry about is the flip side to what Soma's talking about, and that is the most likely outcome of all of this is the use of new technology to present and prepare and deliver holistic solutions for the people who can afford it. And to expand the gap between us and the people who are marginalized and getting hammered the most. So one of the things, we say equity lens, and I don't think that's strong enough. I think we've got to say this, we are all about the bottom 20, 30% of the income scale or whatever cutoff you want to use. But we're talking about investing in the, not just the 3 to 5% that Charlie mentioned, but the 30%. And that's what this is all about, because otherwise it's going to end up with much better health and well-being for people who look like us, or at least like me.
Christine, you want to make any final comments here about your vision and view of what's actually on the ground and how you're pragmatically trying to address these issues in your community?
Well, I was struck by the conversation that's been going on in the chat about the transitions of care. And then I'm held back a little bit by what Soma just said, because again, I think we do have to make sure that those are important things to the people on the ground. Assuming that they are, which is an assumption, I think that might be one of the ways to help move this work forward for us in New Jersey as well as others. It is clearly a big area of challenge, whether it's, kids are ending early intervention at age 3 and then getting lost and not getting into the supports that they need from the school system. It's, children with developmental disabilities or long-standing medical disabilities who are heading from adolescence into adulthood and are not given the tools to, self-manage themselves as adults. There's just so many areas and those that Soma talked about. And I think that maybe there's an opportunity to call those transitions out as an area in which it can help us to drive some of the interest in this change. So, overall, I just want to say that I have so many more examples of things happening around the country, people's enthusiasm for things that they're working on, whether they've occurred yet or not, that it puts me in a much better mind frame as I head into a 2-day federal site visit on our New Jersey Inc. project that starts tomorrow morning. So I just want to give thanks to everybody who participated in this project, and know that I've been taking a lot of notes, and I may be reaching out to you for more details on many, many things, but appreciate, all of your input in this process. We've got 6 years to go, and I hope that by the end of those 6 years that this will be so indispensable that no one could possibly imagine dismantling it at that point in time.
Thank you for that. And I think that's the most interesting and exciting part about this is that there's a timeline. There's an extensive 5-6 year time frame rather to do the work. And so often we look at recommendations and we've got a whole pile of great recommendations. You got to go find the place to do it. You got to find the champions. You got to find the money. You got to find the collaborations. You got to find the partnerships. You got to do all that. And oftentimes it doesn't happen because everybody's already busy. Here, with the fact that it's already in flight, is encouraging that all of the things we've talked about over the last couple of days, and starting with an equity lens, starting with people with lived experience, bringing them into the conversation, but actually building it out in an open framework, an open source, open API, modern way, really represents, in my mind, in the years that I've been doing this work, a really exciting, very real opportunity to take concept theory and go make it happen and do it in a way that's replicable and expansive across the country. So I hope that everyone shares some of that vision, and you are all welcome to continue participating or to start participating in the National Action Agenda and the work that's going to be going forward. There are a bunch of work groups that are out there, technical work groups. There's one on consent to share. There's a variety of other ones. And as we look to partner more closely with WIN and RWJF and Ripple and others, we hope that we'll be able to expedite and accelerate the work with everything that's hopefully coming down with this new administration, so we can make really seismic and structural change in a really short period of time. And that would be awesome. So with that, I want to thank people for making time out. As I said, we'll be posting the videos. You can watch them, share them with your colleagues, the materials, the resources, PowerPoints. You have all the connections to people, so you feel free to connect with people on the hub. You can connect with everybody as well. And just as a closing exercise, very simply, I would invite people to put into the chat, as they've already started to do, just 1 or 2 words to everyone about the experience the last couple of days and what you're leaving with. So be my guest, and then we'll adjourn. And I'll start it off. I have to say, this is more fun standing in a big circle in a room at the closing, but it's wonderful to see the comments. Keep them coming, and then we'll finish. Feel free. With that, I want to thank everyone for participating. I really look forward to talking with all of you and joining with the collaborations that you're already pursuing and generating. So with that, have a great rest of the week, and look forward to talking to you all as we go forward. Thanks much, everyone.